Dear colleague, I'd like to say welcome first for all of you. And this is the third day of our conference, and I really thank you for participating in this conference. Today we have we had before three speakers, but now Dr. Shimin Lee will not be available for this session, so for a health problem. So we will start with Huan Ha Choi. I'm not sure
Yes.
I could pronounce correctly. So
Yes,
he will present us glutamate system in hippocampus and schizophrenia. Please, Juan. Yeah. We have to change the order because of using the time economically. So we'll start with Juan, and later on, Dr. Genel will present his presentation.
Yes. My dear colleagues, my name is Yuanhua Zhou in Taipei. I'm very pleased to be here to present my updated data about the hippocampus function volume in major depressive disorder. I apologize because the COVID-19 pandemic in Taiwan, the border of Taiwan is still locked down, so I cannot attend this meeting. Therefore, I sent the recording video slides to you. I hope we can have a more interactive about the scientific discussion in the future. Today, I would like to present it's a subregion hippocampus volume in first episode, drug-naive major depressive disorder. As we know, major depressive disorder is one of the most frequent and severe psychiatric conditions, which was estimated with a prevalence rate of 15% in general population. Hippocampus is a very important brain area for the pathophysiology of MDD because a substantial body of evidence from basic and clinical research support this idea. There are three major hypotheses for the neurobiology of major depressive disorder. The first one is a serotonin hypothesis. I have presented this data in Symposium 9 in this conference. The second is a neurogenesis in a hippocampus because hippocampus is a very important brain area for major depressive disorder, particularly for the emotional and the cognitive dysfunction. The third one is the dysregulation of the hypothalamus, pituitary gland, pituitary adrenal HPA axis. I will not give you data in this conference, but still we also studied this axis very much. This is simple figures for the hippocampus anatomy and physiological function. As you may see, hippocampus is a small part in the medial part of temporal lobe. It's connected with amygdala, which is also very important for the impulsivity and the emotional control, and connected with thalamus and caudate. This is a small figure showing where the hippocampus is. Hippocampus play a key roles in the function as following, such as learning, cognitive function include memory encoding, consolidation, spatial navigation. This is quite new ideas because hippocampus is a kind of GPS for human brain. of course, emotion regulation. With advances of brain image techniques, we can use PET or SPECT to do the receptor image in human brain. We also can do the metabolism of neuron in the living brain. I have presented this serotonin transporter image in Symposium 9. We also can use MR system to run different image technique with different image techniques, such as we can do the structure image to see the different brain area. We can image the white matter with a diffusion tensor image. We also can measure the functional connectivity between different brain regions. We also can measure with MRS, we can measure the metabolite of some amino acid. The first paper used MRI in major depression was published in 1996 in PNAS, which is a very high impact journal. And in these studies, they use MRI to image hippocampus atrophy in recurrent major depression. As you can see, at that time, even they have a very good result, but the spatial resolution for MRI is not very good. But still, if they measure the total volume of hippocampus between left side and right side, and they found a very important information was that the hippocampus volume has a negative correlation with the course of illness. With the advances of image analysis, people can use automatic segmentation to find out the subfields of hippocampus from the high resolution MRI. So in the early stage, people can measure the total volume, and latterly they can measure the hippocampus volume into three parts, such as head, body, and tail. But with automatic segmentation technique, people can see the transverse, the transverse part of a hippocampus, which can be divided at least 7 to 8 subfields. So as you can see, with the automatic segmentation, you can see the different subfield of hippocampus. So this study was planning to explore the alteration of hippocampus subregion volumes. In the first episode, drug-naive major depressive disorder by two segmentation methods. This is a method and the material. First episode, drug-naive patient with MDD and 35 age gender matched healthy control or recruited. Volume of three subregions of hippocampus along with the longitudinal axis include head, body, and tail was analyzed manually, and 8 transverse subfields were automatically determined by using free software. And in this study, we also add one more biomarker we call an asymmetric index, since as you just seen this, the previous result, when we analyze the volume of hippocampus, we can easily to divide them into left and right side, so we can see the differences between right side and the left side. This is a result since we use high resolution MRI. As you can see in the left part, we can use a manual method to divide the hippocampus into three parts, include head, body, and tail. But we use automatic segmentation. We can divide the hippocampus into the subfields in eight transverse subfields, as you can see this area. This is a demographic data of healthy control and the patient with MDD. As you can see, it's 35, but age, gender matched. There's a differences between this total volume and it's a difference in the MADR score. It's average is 36.7. I would say this patient group is in the moderate to severe situation. First, let's take a look the longitudinal axis of subregions, which include head, body, and tails. Since this table is quite busy, I just want to direct to point out the major findings. The major finding is no matter right or left side, the head part of hippocampus was actually smaller in MDD than healthy control. But this finding cannot be seen in body and the tail part. For the subfield, it's no differences, but I would just want to skip to the asymmetric index since I don't want to give you too much information. You can check the paper later. I will tell you where you can find it, but this is asymmetric index. The major differences is in a very interesting area. It's called CA4DG. DG means dental gyrus, where is the most abundant of neurogenesis in the hippocampus area. So as you can see, the asymmetric index is different between the MDD and the healthy control. So I would like to summarize our result. And first, there was significant reduction in the volume of bilateral hippocampal head in MDD compared with healthy control. Second, the volume of eight subfield were not different between groups. Third, MDD patient had a higher AI, which means asymmetric index values in the subfield of CA4 dental gyrus in MDD. As I just mentioned to you, this area has the most abundant of neurogenesis in the hippocampus area. The fourth is that there was a trend of negative correlation between MADRS scores with a volume of left head hippocampus volume. This is a very important finding in this paper, even it's a borderline p-value just 0.051, but the trend is quite significant. The fifth, there was no significant correlation of MADRS score with AI of hippocampal, CA4, and dental gyrus. We should discuss about this finding because hippocampal volume reduction was reported in, to underline depressive symptomatology. However, the evidence in today remains inconclusive. I think many factors can influence these results, such as we use different patient group, we use different methods to do image analysis. Even we use a different protocol for MR scan. The second is the current study has several limitations. Particular, given the cross-sectional study design, we cannot derive the causal relationship. let's make a conclusion. It's a change in hippocampus subregion valence might be an image biomarker in the first episode, drug-naive patient with MDD, particularly for the left side of hippocampal head, because not only this area has a smaller, smaller volume compared with a healthy volunteer. In particular, this area, the reduction of this volume is a correlation with clinical significant, or you can say clinical symptom severity. So this might be a biomarker for MDD. This paper has been published in Neuroscience Later recently. You may check this paper online. I would like to thank the group in radiology and the nuclear medicine department in my hospital, Taipei Veterans General Hospital. This picture is very famous. It's the very highest mountain where located in the east part of Taiwan. This sea is the Pacific Ocean. Across this Pacific Ocean, that's the United States. So it's very, it's a very beautiful landscape. I hope you can visit Taiwan next time. Particularly in the next year, we will hold the CRMP meeting in Taiwan. Hope see you in Taipei. Thank you for your attention.
Thank you. Is there any question from the audience? Yes, please. Can you talk to Mike, please?
Thank you. Yanhua, it's Andy Greenshaw. How are you? Thank
Good,
you.
good. Good to see you.
A really very nice presentation today. I have two questions for you. One is about the asymmetry index. I think it's very interesting when we have asymmetric findings in human brain. And we do have general tendencies in lateralization. But can you speculate on what the significance of a lateralized change would be in relation to depression?
Okay. Yeah, thank you, Andy. Yes, I think the lateralization of human brain maybe play a very important role in the pathophysiology of depression. And in this study, I think the most interesting part is, we just find several selected regions. And in particular, we found this asymmetric index in a very important subfield for hippocampus. So I think we should explore in that way. But unfortunately, we cannot find the correlation with the clinical symptoms in that area. So I expect maybe the small sample size. That's the first thing. The second, maybe we could enlarge our sample size. And secondly is we should follow up this group, and actually we are doing that. So we want to see the longitudinal change of this asymmetric index for this patient group. Yeah, that's my answer. Indeed.
Thank you so much. I have one other question for you. And because I know you, I hope you forgive me because it's a difficult question, I think, but a general one. In these studies of particularly areas like hippocampus, it's very difficult to control for all of the factors. And the study you presented is excellent and technically demanding. But when I see the demographics, I always think about what is missing. And I think about epigenetics. So I think about what was the family history of the people in the study? Was it different among the people in the depression group? And to what extent was there adverse early childhood experience? So I wonder if you could talk, it's a really difficult thing to control for, but I wonder if you could talk about it, because you did mention the HPA axis, and we know the work of Michael Meany and so on. Hippocampus is exquisitely sensitive to these things. Thanks.
Yes, yes. It's really important since we can we can expect a lot of confounding factors. But for this study, we did not to measure the family history. And another point is it's also quite difficult to to define the family history. Generally, I think in the clinical situation, a clinician only ask this question very rough. If you have a family, but some patient they have a family, families fit the criteria for FDD, but some families they are not. So I would say it's really difficult to find out the role of family history in this study. But thank you for your opinion. Maybe we can check the medical records later, and by the medical record, and see if we can find any particular things. Yeah, thank you, Andy.
Is there any other question from the audience? We still have enough time since we just have 2 speakers, so please feel free to ask any question. Okay, thank you, Juan. Now we will move to another speaker. I'm sure you all know him very well, but let me introduce him as Professor Ali Saffet Günis from Ege University. He's an opinion leader in neuroimaging of psychiatric disorders, mainly mood and psychiatric disorders. Now he will present us the effect of primary negative symptoms on brain structure in schizophrenia, a 5-year follow-up study.
Thank you very much, Kürşat. Should we present it in English or Turkish?
The problem is what we should do about the language. Should be in English or in Turkish. Ama şimdi Türkiye'de de İngilizce sunmak.
But it's a bit weird if I present it in English in Turkey. So let me present it in Turkish. This is the presentation of a trial, as did the previous speaker. And let me first try to tell you why we carried out this study. Schizophrenia, as you all know, is a heterogeneous disease. There is no debate about its heterogeneity, and patients do not like each other. And the DSM system helps, but not enough all the time. Yes, it helps us with the diagnosis and the treatment, but it's not enough. When we look at the symptom trajectories and prognostic trajectories, there are serious debates going on. And since the past, since Blurier and Kraperin, we have the habit of clustering the symptoms. So we have positive, negative, cognitive, and affective clusters for our symptoms. And there are some sub-classifications for them too. And there are trials on these clusters as well. Of course, our approach was considering it as a single disease, and the negative symptoms appeared in the early phases, and it goes on in the interepisodic periods of the disease. And since it's about the functionality of the patient, we know that these are the main symptoms. The negative symptoms are the main symptoms, but there are also positive ones. There is the Jacksonian thought period. And although there are many studies about it, we are not very clear about it, because there was a kind of distinction whether there is positive and negative schizophrenia, and T.J. Grow unfortunately lost his life, and he made a classification such as type 1 or type 2 schizophrenia, and those who have severe schizophrenia have more negative effects. And there were also some dimensional approaches. G. Manos and Kingsgold and Robert Murray also led this process, and dopaminergic dysfunction and psychosis can be based on some other sub-processes. But today we have data-driven approaches, and we follow the patients for a short or long while and then classify the patients accordingly. And here you can see that there is a team working on this topic. And we're always trying to make it simpler to understand, but also we should have some operational criteria to help us. And I always remember Einstein's quote about this thing: everything should be made as simple as possible, but not simpler. There are many trials about the negative symptoms in schizophrenia. We are involved in some of them. For instance, Enigma Consortium, we are a member of it, and Wan Haren is also in that consortium. And what we find in general is that when we look at SANS or PANS scale, the negative symptoms and bad prognosis groups show that they have less gray matter, and lateral ventricles are more enlarged. And when we look at the scores, orbitofrontal cortex have less gray matter. This is reported by the measurements or the scales. So we know the prognosis is bad and they have some negative symptoms. So what we expect is to see some more degenerative process. I mean, there will be less gray matter, and lateral ventricle, in parallel to the level of gray matter, will be enlarged because it has lots of gray matter in the lateral ventricle. And when we focus on the negative symptoms, Carpenter and his colleagues, and Greg Bryan, for instance, developed a different perspective with regards to identifying the negative symptoms, because the patients have depression and anxiety, and this increases the negative symptoms. And we know that EPS is increased, and there could be medication side effects or lack of stimuli or some lack of social relations. These all increase negative symptoms, and these are the main neurodevelopmental findings. And if we put them aside and follow our patients for 1 year, then we can see the negative symptoms in the disease, and we could be more able to diagnose it clearly or accurately. And here comes the deficit schizophrenia. As you all know, almost 15 to 20% of the patients can be diagnosed with deficit schizophrenia, especially for the first episode they have. And chronic patients, 30 to 40% of the chronic patients may be deficit schizophrenia. And when we look at the long-term follow-ups and some MRI images, there are some findings that there could be a deficit group. This is my trial on deficit schizophrenia. I started working on it in 1990s, and Sometimes the findings were not in compliance with the literature at that time, but at the beginning of 2000s, a team from our group focused on deficit and non-deficit schizophrenia, and they carried out a trial to focus on the level of gray matter in those two groups. And in negative symptom group, we expected to see less gray matter, but at that time, it was really interesting to see that when we compared the deficit group with the control group, there was a reduction in gray matter, and we compared the non-deficit group with the control group. However, their difference was much, much less. So at that time, this was an unexpected finding, and when we go into the details of the literature, we find that in the deficit group, there is more gray matter in the frontal cortex in those patients. So we were not alone. We were not the only ones who found this finding. And when we compare deficit and non-deficit, you can see dorsomedial gray matter increase and also gray matter increase in the temporal cortex, according to the study published in 2015. And there were lots of studies on autism at that time, and you know that the autistic patients have more gray matter, and it was said that this could be related with the neuroplasticity. Therefore, maybe it could be the same for the deficit schizophrenia, we thought. There could be some pruning or the dynamism in the gray matter may be lost. That was our thought, but this is the only study, and it's not in line with the literature findings. Yes, some of the findings are in line with the literature, but some of them were not. Therefore, we conducted another trial, and we wanted to have a clear result about this. So we said that the group that we used in 2012 was not used here. This was another group because if we make a longitudinal trial, the patients could be a control group within themselves, and there were other studies as well. This is a meta-analysis of structural neuroimaging studies. I believe it was published this year or last year, and you can see several studies from our colleagues as well. And there was a really interesting finding. It is said that our findings show that between deficit and non-deficit schizophrenia patients, there are not much differences with regards to the gray matter volume. And they said that they compared it to healthy controls. There is a difference between healthy control and deficit schizophrenia patients, but there is not much difference between non-deficit and healthy controls. Therefore, it's not much possible to make a distinction, clear distinction, and this is the result of the meta-analysis. Therefore, this also supports the heterogeneous data we have in the literature, and the results of the studies do not always overlap with each other. When we look at the lateral ventricle, for instance, some studies find correlation with it and some studies don't. We carried out a 5-year follow-up for our patients. We recorded the videos, all of our patients. We tried to follow up all the patients for 5 years, and some of them unfortunately dropped out of the study after a while. And one of our colleagues is now working at Chapa now. He went outside, and then we trained Gülser, and she worked on those scorings. And then we have the computer genius Özgün. He is in Sweden now, and he focused on all the matters we are working with. And Cenan is also the leading researcher working with Gülser and Irmak. Let's look at the 5-year outcomes. We have negative symptoms, and even at the beginning or even at the end of the trial, we see that there are huge differences with regards to the negative symptoms according to PANSS. And according to SANS, again, we see that deficit patients have more negative symptoms. And in this trial, we followed 14 deficit patients for 5 years, and we followed 27 non-deficit patients and 18 control patients. In this trial, the statistical analysis is very important in such a longitudinal trial, and you must have controls as a baseline, but we used a linear mixed effects model, and the total brain volume, age, and gender were compounding factors in this trial. The most important characteristics of this model is that it shows us the relation between the group and time. On the left-hand side and on the right-hand side, you can see left lateral ventricle and right lateral ventricle. And here, the patient's ages are similar, and also the time they have the disease are similar. So on this part, we can see that schizophrenic patients have higher figures in this respect. But when you look at the trajectory in 5 years, it goes down a little bit. And when we look at the deficit group with the same age group, we can see that there is not much difference. I mean, if you evaluate the data, it will be almost the same. But when you take this baseline and look at the result, there will be a greater difference at the end. You can see it in both ventricles. Therefore, this can explain the incompliance with the literature, because the time you compare is very important, and also the deficit group is different from the non-deficit group, and this is shown with this stroke statistical analysis, because we use the baseline as the control. This is the 3D analysis of the left lateral ventricle. Only some parts of it is enlarged, not all of it is enlarged. And here you can see that some specific areas of lateral ventricle is enlarged, not all of it. So, in conclusion, yes, there is heterogeneity, and this is why we have primary enduring symptoms. And when we compare the two groups, there is a difference in trajectory in biological and clinical terms. Especially in biological terms, our findings support this argument. So, from the very beginning, the reason why we compared deficit and non-deficit groups was to find out whether the neuroplasticity of the deficit group was poorer, because it will be a very important finding for us. And in the next study, we will be focusing on the neuroplasticity of the schizophrenia patients without making a distinction between deficit and non-deficit schizophrenia. And this will also show us the difference between the patient groups. And I believe it will be published this year in psychiatry research neuroimaging. Thank you very much for your attention. Thank you for this nice presentation. We have a question at the back. Can you pass the microphone, please? I have two questions, Safet. I believe these patients are using drugs. You are following them for 5 years, and did you control the drug use, or do they use similar drugs in similar modes in terms of neuroplasticity? And the other one is that when you have schizophrenia patients, how do you scan them in MRI? How do you keep them in the MRI scanner? Can you please explain this as well? Thank you. I didn't give much details, but the drug was the question that was asked before, and the correlation. When we look at the correlation between the left and right ventricles with regards to negative symptoms, there is not much difference. And when we look at the drugs, there was no correlation either. So it was a confounding factor. One of the interesting findings was that when the patients were first enrolled, non-deficit patients were using high doses of drugs, but later on we saw that deficit patients were using higher doses at the end of the trial. Of course, this is based on the clinician's choices, so I believe the patients were given higher doses because they didn't improve. Of course, it has a negative effect on primary symptoms, but as I have said before, we had the chance to watch the videos of patients that were taken 2 years before or 5 years before, and we know that the diagnosis was made 5 years ago for those patients. So even if negative symptoms increased based on the dose, although they were not too much, it helped us. But drug issue is a little bit complicated, and its effect is also a little bit complicated because it affects the neuroplasticity. Sometimes it increases or sometimes it reduces, and I believe at the optimal level the patient's performance will be improved, and it's not possible to eliminate it by 100%, as mentioned by the previous speaker. Keeping the patients in MRI scanner, of course, this is a structural MRI, so it's relatively short. I believe it was the flash sequence, and this is a shorter sequence. And since if it's not fMRI, the patients are in the scanner for a shorter period of time. There are a couple of motivators. The first one is that they have a long relationship with us, and they may not have experience with such devices, but sometimes the families want their family members to be involved in such studies, and unfortunately some patients do not want to come and they don't want to attend. And of course, as you said, fMRI is more problematic because their motivation is very important. Unfortunately, it's a bit more problematic, and we want to have DTI too, but I don't support this because it takes a long time and it's noisier and it's harder for our patients, and it gives us less information than we want. Therefore, our purpose is to have the patients into the MRI and do the scanning and let the patient go. Any other question or comment? The third speaker will not be here because of health conditions, so we can have time for questions. Yes, please.
Thank you. Thank you very much for a very nice talk. We do some neuroimaging in my group, and I know how difficult this is and how much work goes into generating these data. And to be part of these consortia is really important. So I have two questions. They're kind of related.
Let me come there because
Oh, sure. Yeah. One question is, now this very important finding that you can't differentiate between deficit and non-deficit patients based on global gray matter changes. And now you want to focus on neuroplasticity. But the previous question you addressed the issues of the difficulty of doing functional imaging with patients. So I'm wondering what line of research, if it's clear to you yet, are you going to follow to try and tie in these findings to, I would guess, just as a suggestion, the responsiveness of some of these patients to drugs like clozapine, for example, because the whole issue is managing these deficit symptoms.
Okay. I'll prefer to speak in English because it's much easier to at least give my ideas to you, I think. I'm always thinking about why we cannot increase motivation, or why those people are so, the evolution is the real problem with those people, and it is very hard for them to learn social interaction and all those stuff. I mean, why these people are so eager not to learn or not to participate in any of these activities, or of course there's a reward system dysfunction and the other things, but it's also seems that all the systems is not very good at learning contingencies and these kind of stuff. So one thing that I think actually is because of it's not just because the deficit, I mean a whole other literature about those people doing stem cell research from the schizophrenia patients, and it shows that their neuroplasticity does not go well. But if we can differentiate or at least show it in vivo that the neuroplasticity system does not working very well in schizophrenia, we may change our target to treat them. So while we are thinking and doing those things, we started to do something. Perhaps it might be the answer of your question. What we do now is we are getting a resting state fMRI, and then start to do them after that fMRI. We remove that patient from the fMRI and start to do them some implicit learning tasks. So it's not something that the patients just following up the instructions, and it's a very easy thing. And the people before us that shows that immediate if you get that and after that task, if you put them again in the resting state, you see that the low amplitude fluctuations are changing. And even after you did your motor task, your brain is practicing some way of practicing that. So this actually leads us to that. So we are thinking that the primary enduring negative symptom patients might have less activity in those areas. I mean, because one thing everybody noticed that. I mean, when you are with the patient, when you start to work with them, they follow you up. But when you leave them, they stop doing what they are doing. This is one problem in social treatments. So, I mean, you always accompany to the patient. So this is the point that we try to show, if it's really like that. I mean, yes, because we showed that your brain is still doing something, even after you played your implicit learning task and you go to the MRI and your resting state is different now. And we try to focus on how the schizophrenia patients is doing. And we almost reach our data to show it. And the next step is what is the negative symptoms, the effect of the negative symptoms. If it is so, we may, I mean, at least differentiate. I mean, we are not, there's no need to put all the patients in the same treatment strategy, and we may differentiate them in different terms. This was our aim.
Since we have time, can I ask one more question?
Sure.
Yeah. It's a question, but it's a comment. So yesterday, one of the researchers from Belgium gave a presentation on emerging psychosis and looked at some deficit symptom profile. And she was talking about this classical feature of anhedonia. And I was surprised by the results that she presented, because if you do the standard testing for anhedonia, you're looking at what the response is from the patient, what they report. But she actually did some testing in which they presented these young adults with rewarding stimuli and measured the responses. And her results indicate that it wasn't really anhedonia in terms of an inability to process reward. It was actually that they didn't report positive experiences from things that were normally rewarding. And she talked about the individual handling of a schizophrenia patient and how lifestyle and social supports made a difference. And that I hadn't thought about that before. I'm not sure if it's within the scope of your practice and what you thought about. But in terms of trying to get a handle on deficits, if the brain is in a situation where it can be changed, there can be some way of motivating patients. And you mentioned that when they're there, they'll do it. When you walk away, they won't. And they live in a system generally that's not very reinforcing or rewarding. They struggle. They're very informal comments, but I wonder what you think about that.
In my background, I was working with neurovolcos, so the addiction and the reward system is always is one of my interests, and also the findings from that area also directed us to work on this, because there is problems with the prediction error and when you get and how much probability that a patient get that reward. So it seems that the schizophrenia patient is very low. So I totally agree with my colleague from Belgium, and we are following up this literature very closely, and it's also directs us to that studies, because it seems that at least the learning procedures, especially implicit learning procedures and evaluation of reward contingencies, are not similar between patients and the controls. So, and also within the patients groups, because some patients are doing great, surprisingly great. So I think these are but these are the things that we are just putting us in that path to understand what kind of neuroplasticity deficits, because my team, half of my team is working on artificial intelligence, especially deep brain learning and, deep learning networks, not deep brain learning. So one thing that we see, and that many other peoples are focusing on, what's the difference between the deep learning and the neural networks and the real brain learning. And one thing that everybody agrees on, which I also, is the neuroplasticity of the brain. That's why it's so plastic, so to flexibly learning the things. So I think this is one thing that schizophrenia patients is losing in, and if we have quantify the plasticity deficit and which areas are the most one, probably every place, but then we can focus on new approaches, because for now the drugs or medicine is limiting us, and so we need some other procedures. This is why we are focusing on this topic, and many people, as you said before, are contributing to the literature, and if we just look at the whole picture together, it seems very, it's very, let's say, collective picture to us.
Yeah, I think that's a great answer. In my view, it's like we've been dealing with the basic building blocks of the brain for a long time, and some of the newer neuroimaging techniques and machine learning and AI provide us with a new kind of hyper view of things, and possibly we'll be able to bring in other kinds of therapy to move things forward. So it's almost like we don't have a 3D view of schizophrenia. We have a kind of 2D, old traditional view, and trying to get past that is quite difficult. But I think this kind of work is really promising in that way.
Just last sentence, I can say that my dream is like when we look at the developments like Elon Musk and the things, if we can connect some kind of an extra help, like with chips that he did in pigs, with the different parts of the brain, like hippocampi and the other parts, or recreating, or if we can modulate some predictive error things or help these kind of stuff, so we can compensate things. So I think this might, a dream for now, but sometimes it might work in the future. Thank you.
Arka tarafa mikrofon uzatabilir miyiz? Oradan da bir soru.
Can you pass the microphone to the back row? Thank you so much. I would like to congratulate you for this study. We have the deficit syndrome, and this could be different from the usual schizophrenia, and it can be seen in other diseases such as Parkinson's and etc. And it has some negative effects. We know that, and this is a very serious area, and we have been expecting this study for a while. I would like to ask a couple of questions. Do you have any data about the family history of the patients? And the other one is that eating habits are very important with regards to the brain area volumes. For instance, some people fast for a while, and therefore there is a reduction in brain volume, but when they go back to normal eating scheme, then their brain size goes to normal. So we know that those patients have negative symptoms, and but they may be having eating disorders, and this may be affecting the brain volume maybe. And the other factor is that there are social treatments, social support treatments. You have deficit and non-deficit group patients, and which one of those were receiving psychotherapy? Do you have data about this? And we have typical and atypical ones, and we know that atypicals actually increase the neurogenesis. Did you see any difference in this respect? And did you have any data about the body mass indexes of those patients? Thank you. We have some scales here. These are the traditional scales, but also we have some specific scales. We have about the family relations and family burden. We have semi-structured scales like this. So we check the data about the family. So while we reduce the data, we check the weight and BMI and family history of the patient, and these are checked whether they have a compounding factor effect or not. But they don't always have clear effects, and it just complicates the model further. And family burden or BMI and etc. are reduced in this data. And this is why we have Özgün in our group. He is a very important member of our group. And there are many factors that affect the brain volume, as you said. For instance, blood glucose levels, migraine, and other factors. And All these factors may affect the brain structure, but we know that second generation drugs also affect the blood glucose level, and there may be other factors. However, when we look at the data, we see that
sorduğumuz bağımsız değişken, bağımlı değişkeni ne kadar açıklıyor? Burada
it must explain the dependent or independent variants we ask, but we only get the explanation from this data. And I can tell you that it explains by 30 to 40%. So you have a remaining 60 to 70%. It could be because of the errors or some other factors, and they are already included in the model, whether you like them or not. But we made a distinction between deficit and non-deficit group, and despite everything, within this orthogonal model, it explains the enlargement we see. And lateral orbitofrontal cortex shows some difference in between two groups, but we didn't focus on it much, and we need another dependent variant there, and the statistical model will be more complicated. So we focused on the most strong side. These are the ventricles. But yes, you are right. All these factors have an effect. We have the same thing for COVID. But at least as a model, we managed to make a distinction between deficit and non-deficit groups and their relation with the enlargement in the ventricles. Any other question or comment? Okay, if not, we can close the session. Thank you very much for being here early in the morning and for your active participation. This is the end of the session. Have a nice congress.